you'll you'll have noticed that the on-site or the online website was crashing. Their telephone systems became completely overwhelmed. My understanding was they went from like 200 calls a day to over 3,000 calls a day, and that was before the PPP plan went into place. So what they did, that these loan applications are now going to be processed through a local lender, and so you'll want to contact your local lender to make sure they are an SBA 7A lender. This approach is kind of a nice thing for everyone involved. We don't have to deal with the SBA in each of their locations, a stranger. We can actually deal with someone that's a local lender, someone we know, probably even our own banker, to help guide us and get us through the application process. So next slide. So who's eligible for these plans, for the PPP loans? If you're an employer and you have fewer than 500 employees, you're eligible. And there's a few exceptions for folks that, if you're in the food industry, if you have a franchise food company or an entity, there's an exception to the 500. Sole proprietors, independent contractors, and self-employed individuals are also eligible. So if we have folks that are, 1099 folks out there, sole proprietors, just know that you're also available to participate in the plan. And the the caveat here is you must have been in operation as of February 15th, 2020. Next slide. There you go. Okay, so how do affiliations affect the eligibility for the plans? Typically, there must be. You include other affiliations that you may have in applying the size test to determine whether or not you are, quote unquote, a small business. And so there are certain affiliation requirements that have been waived through the process. But as we look at the loan application itself, there are certain things that have not been waived. Like, one of the things is they want to make sure that you or any affiliated partner you're with is not someone who's been suspended or debarred from participating in a federal program. You're not presently involved, you were an affiliate, or not presently involved in a bankruptcy. You're not someone who's delinquent on an SBA loan that's already in existence. So those all make sense. And so the one thing that, when you read the application, and the application has moved through various stages, and this question has remained consistent throughout, but it says, is the business or any owner an owner of any other business or common management with any other business? If the answer to that is yes, you attach a listing of your affiliates as an addendum A. And so the advice that I heard, the advice that I was given through our lender was, look, err on the side of being transparent. They're not using this as something to disqualify folks for the loan. They're actually looking for the potential of people to double dip in the program, right? They're concerned that the group itself could apply for and include other small entities, sole proprietors, things like that, into their application, and then that individual contractor could go off and do it themselves, and therefore we have an instance where someone's double dipped. Next page. So, oh good, we changed this. So how much can be borrowed on these loans? And the amount is limited to the lesser of $10 million or 2.5 times your average monthly payroll costs for the prior year. So that has become, if you look at this asterisk here, it excludes the prorated portion of any annual compensation above $100,000 for any person. And so if you are a nerd like me or anybody else who reads this stuff, the legislation on this is unclear. And so what is that? Does the $100,000 cap at or include benefits, or does it include retirement funding? And those are all something that I would say look closely at what the bank is providing you and the information that you need to provide to them as to whether or not what you can include and what you are having to exclude as far as the cap is concerned. So either way that the cap exists there, it's not going to make you whole entirely, but you do want to try to get, obviously, as much money out of this as you can. And the payment terms are a 2-year term at 1% interest. And that was 0.5% interest as of last night, and as of this morning, it just moved to 1%. So again, things are changing constantly. Waivers, I'm gonna go back to that real quick. Yeah, as far as a waiver, unlike other SBA loans, you don't have to show that you can get credit elsewhere. You also don't have to have or provide any collateral, and there's no personal guarantees associated with these loans. So, next slide. So how can PPP loan proceeds be used? The proceeds can be used for the following, and if you use them for these types of expenses, they're eligible for forgiveness. So payroll costs, excluding the prorated portion of any compensation above $100,000 per year for any person. Again, look closely at what the bank is going to provide you as far as what to include, if you can include benefits, and if you can include retirement benefits as well. In that, we're seeing variations, and I think there's some defining moments that need to occur before we know exactly what their true intentions are. Mortgage interest on debt that existed, rent, and utilities. There is an 8-week window. So from the moment you receive funding, there's an 8-week window that you are going to look at to determine what amounts are forgiven. So think of it in this way. The data that's going to be required is going to be payroll costs related to 2019. And so that's the determination to determine the amount of the loan that you can apply for. The period that's going to be under scrutiny for forgiveness is going to be based on 2020 information. So that's important. And that money is based on from the time you get the funding, the 8-week period that you spend it. Next slide. Okay, so what's the catch? Under the program, what it is meant to ensure that businesses have the funds to pay their employees and to prevent layoffs or furloughs. The loan is forgivable if you use it for those intended purposes and you maintain your workforce. The amount is forgiven, or the amount that's forgiven will be reduced proportionally to any amount of work that's reduced. So in general layman terms, you cannot apply for it, take the money, and then lay off all your employees. That's what they're trying to prevent folks from happening. You can have folks that are already in a position where they are reduced hours or they are on furlough, and the goal would be from the moment you receive the funding for the next 8 weeks, you would want to bring those folks back on the payroll, and that's what would be included in that. So any accrued interest would need to be paid back, and those can actually be deferred six months, maybe possibly even up to a year. That's again based on what we know now. And the forgiveness amounts of the debt would not be included in taxable income. So that's important as well. So when does the application process actually begin? Begins today. Small businesses, sole proprietorships, they can apply for and begin receiving funds as far as we know it today. We do know that independent contractors, self-employed individuals, they're not eligible to start the process until April 10th. So what we would say is there's been articles out there currently that show certain banks are more ready than other banks. Certain banks are already beginning to fund. Certain banks are waiting for clarity on the legislation to come out today. They hope in order to be able to process these loans, underwrite these loans. There's concerns that the volume of loans that people are going in and applying for, they still have to take that information and push it up to the SBA, and those systems are under suspect that they may not be able to hold the volume that they're going to be getting over the next couple of weeks. So what I'd say is don't delay. Beat the clock, start now. If you haven't pulled the information together, communicated with your banker, you need to do that now. And so next slide. There's a kind of a common list of items that you need to gather. And it varies lender to lender because again, it's not very clear what each lender is requiring because it's unclear how the rules are written through the SBA. So each lender is kind of making up as they go along in some cases. But have your most recent tax returns ready. Have your payroll costs. You're going to need that to calculate your monthly rate times your 2.5. So you're going to have those payroll costs year to date available. They're looking for the average number of employees. That'll all be included in your payroll tax filings, 941s, things like that. W-2 copies, any 1099s you may have, and then a trailing 12-month profit and loss statement. So we provide a link down here to the SBA where the application can be found. From what we understand, what we've heard is that the form continues to change. It just changed and came out with a new form this morning. So kind of interesting. Some folks have already signed off on all this, and we're having to redo it. But we've also heard that even the form that's come out today may not be the final form that's used. So under that circumstance, take what they have, gather the information, fill out the form. You can always go back and re-sign if you need to. That's kind of the approach we've taken, and it seems to be working. So I hope that was helpful. I hope.
Great.
Yeah. Thank you.
Thank you, Brian. We're going to have time, hopefully at the end, Lisa, if we can unmute everybody at the end. I'm going to burn through some other aspects of what's happened, and as Brian put it, in COVID 1.0, 2.0, 3.0, and then we'll open up for questions at the end. So the CARES Act has created, as you've probably heard, a $100 billion fund for hospitals and clinicians who are enrolled in Medicare or Medicaid. Contrary to conventional wisdom, this is not a hospital-only fund. You clinicians, because you're enrolled in those programs, are eligible for this money. Now, the grants for this money, and these are grants, this isn't a loan, this isn't an advance like other programs we're going to talk about, are for expenses and losses that are attributed to the coronavirus. And this is set up by Congress as a fund of last resort. So to Brian's point on the payroll, if the government's going to pick up payroll costs for you for 8 weeks, that is not something that you would want to turn around and ask for reimbursement from the public health fund. So you have to be careful in terms of how you present that as a, if you will, as a claim to the fund. Now, your major categories are pretty straightforward. Your volume and revenue shortfalls. We're hearing from across our client base, and I'm hearing through EDPMA and ACEP, ranges in the low of -20 to -50%. So you've got that. You've got increased costs for surge capacity, replacing FTEs for quarantined or sick physicians, for additional medical director time. One tip for all of you is have your medical directors and your assistant medical directors record the time that they're spending devoted to COVID-19. The meetings that they're involved with, the setting up of the tent, if you're using that, or another building, or different EMTALA protocols, based on what we just heard on the ACEP call. Anything that has to do with COVID-related treatment, setting up, implementing a telehealth program, if you're going to do telehealth through more of a formalized service as opposed to a Skype or a FaceTime. And then, of course, if you're buying your own PPE, you're traveling, you've got hotel and related expenses. Those are all potential categories. Now, I'm not speaking on behalf of ACEP and EDPMA. I'm just giving you a perspective as a member of the EDPMA board and kind of where we're going with our special task force that was devoted to focusing on this. And this is happening literally in real time. So to Brian's point, this is so fluid. It's in my 26 plus years, I haven't seen anything like the torrent of laws and regs that we've had come out. So the Hospital Association made a real simple pitch to the Secretary of HHS. They said, we want $25,000 per hospital bed, but if they're in a hot zone, we want $30,000. Now, if you do the numbers on the number of hospital beds in America, that figures out to be, let's call it ballpark, about 28 to 30 billion. That leaves a lot of money left, right? So we wanted to take kind of a page from the AHA and say, what would be a straightforward, immediate request for immediate funding? Not something we're going to wait on, but something you would get immediately. So we took, and this was largely through the works of Dr. Bettinger, Dr. Randy Pilgrim, Dr. Cirillo, Aaron Goldfeld, and a group of folks who were working on this. And we came up with a formula using the Medicare 2018 data that would simply look at your volume, say in the last during the public health crisis. We picked a four-month period, and what your revenue losses would be versus your 2019 volume. And so it was a simple ask of saying, we want a number based on that Medicare value and the volume losses, and that would be, again, an immediate request for funding. And just to give you a ballpark number, that comes out to about $3.624 billion across every emergency physician in America. Now, guys, you've got to give us some slack here, because this is happening in real time. We heard this morning that the vice president was getting ready to distribute funds very quickly to hospitals out of this fund. And our biggest fear, of course, is that $100 billion will vanish to the hospitals, which, and there are definitely hospitals that are needy of it and entitled to it. I'm not making that argument. I'm just saying we had to move extremely fast to get this in. So that's the initial ask. And then there will be additional tranches of funding that we would develop a process for, where you'd be able to again, capture your expenses for PPE or your expenses for, hotels, meals, various other expenses, and medical director time. So we would probably also, of course, support this notion that AHA had, which was hotspots would receive a priority and potentially an increased and incremental funding versus other areas. I just want you to know the one good thing about having the dozens of decades of experience that we have with the individuals I just mentioned and with others at ACEP is that we have deep relationships with folks at CMS and our advisors and our lawyers, and we're at the table. Okay, I can't guarantee anybody that will be successful, but we're very much at the table, and this is money that you're entitled to, and we're making the argument for you right as we speak. So hopefully you'll, for those members of EDPMA, you'll be able to see that letter very shortly. And I'm happy to take some more questions on that later. Okay, the accelerated and advanced payments programs. For the home gamers, this program's been around for a long time. It's popped up during various public health emergencies, natural disasters, and such. And if you think of this as your very fastest way to get money right now, okay? So it's eligibility. Any group or clinician who's billed Medicare for the past 180 days, you can get up to 3 months of an advance payment. It's not a loan or a grant. You're going to have to pay it back. The Medicare MAC is going to administer both the payment of the money and the recoupment. Believe it or not, CMS told the MACs they have 7 calendar days to review and approve the request. I hope there's nobody on from a MAC, but a MAC can't really decide kind of what to have for lunch in 7 days. So God bless them if they can do all of this in 7 days. But that's what the directive is. So on the website I mentioned, we have in a document for the advance payment where we summarize advance payments, we have all the Medicare links. It's the second one. We have a part 1 summary and a part 2. In the part 2 summary, we have a link to all the MAC websites. And you want either you or your RCM people, you want them to go there and look at the details of the program because the MACs are going to administer it. So let's go a real quick example. Let's say, I'll pick on Lisa. Let's say Lisa's group gets $250,000 per month. I'm making these numbers up. I have no idea how much they get. So their advance would be, I'm sorry, it says 750, should be 750K. So their 750K advance is on April 1st, okay? So CMS has working with Jeff Davis, and I asked the question, and he was able to get an immediate response from CMS, and I credit them for that. They said that they're going to look at Q4 2019 payments. And so based on that, that's how they're going to estimate your advance payment. So let's say that advance payment in Lisa's group would total $750K. They're going to continue to file claims with Medicare. Recoupments will not begin until August 1st, okay? So there's a 4-month period. They don't take any money back. You keep filing your claims. Then on August 1st, recoupments will begin and go for 3 months until November 1st. So the rules say the money has to be paid back in its entirety 210 days from the issuance of the advance payment. However, the other thing that CMS said to Jeff Davis at ACEP is contact your MAC and ask them for additional time. Why? It's the X factor I refer to here. What happens if Lisa's group's numbers don't return in August? Everybody knows in this business, from a business side, Q3 is the lightest quarter of any ED. I don't want to overstate it. Most groups have a lighter quarter in Q3 than they do any other quarter of the year. So that repayment might start in a quarter that's naturally light, and it might be even more light now because of COVID-19. So the point is that what you want to do is have your director, your RCM person, go into the MAC and say, hey, what happens when the recoupment starts? Can I have another 60 or 90 days if, in fact, that money isn't paid back? And you might ask, well, what happens if Lisa's group does that and they end up with a $50,000 payable back to the MAC? In other words, the recoupments by the end of October haven't made up for the advancement. Do they charge interest? Again, we've heard this is third hand from somebody who was on a webcast. Jeffrey was told this number, that CMS has to charge interest at 10.25% on the amount that's left. Now, that's why you ask for more time if the MAC will grant it. The MAC does not have to grant it, but CMS is saying that they have the authority to grant more time. So contact your MAC and ask them for that additional time. But if you want fast money, this is the way to get it if your group is really in need. But just know that there is that X factor in terms of the back end. Okay, finally, I want to touch on some of the important reimbursement provisions, and then we'll open it up for questions if we're able to do that, if the tech gods are now smiling upon us. So between COVID 2.0, the Families First, and COVID 3.0, testing and treatment will be paid by Medicare, that's my abbreviation, MCA, MCD, Medicaid, TRICARE, Medicare Advantage, and commercial plans at no cost sharing to the patient. I know there are folks that are out there that are saying, I'll see it when I believe it. I'll see it when I see it in an EOB or a remittance advice. I get it. I totally get it. But a lot of these plans have come out publicly on their website, and you want to screenshot it when they do, and they've said, we're going to pay for treatment and testing. Some have even gone further in bullet 2 and said, and I mentioned UHC, Anthem, Blue Cross and Blue Shield of North Carolina, Cigna, Humana, they're waiving cost sharing for physician office, urgent care, ED place of service, and telehealth. True telehealth, audio and video, not audio alone, during the public health emergency. They've said they're going to pay full allowable, no patient cost sharing. What's more, between COVID 2.0 and 3.0, the uninsured, believe it or not, are going to be temporarily enrolled in Medicaid, and the states are getting about 6.5% of their normal FMAP just to administer the program, and the uninsured are going to be reimbursed under Medicaid for testing and treatment. Now, if you have a patient, you've got a problem, you can't get them tested, and you just do your normal workup, then the claim is going to be adjudicated per the patient's standard policy terms. That's what we think so far. But the other thing is key, and there's a macro on our website, an ED COVID macro. You want to use a macro that captures all of these patients, your rule in and rule outs. You want to make sure that you're capturing that for the reasons that we just covered, because these plans and these government payers are saying they're going to pay them at par with no patient cost sharing. The final point is, even if you end up in a situation with a government payer, believe it or not, the government said you can, on a case-by-case basis, you can waive the patient cost sharing for Medicare and Medicaid governmental payers. Please consult with counsel. Please consult with your compliance advisors on that point, because since 1994, that has been an absolute no-no. But under the public health crisis, they've said, if you have a situation and you're going to waive the cost sharing, that's allowable. But just know, so there are going to be some that may be pre the CARES Act. The CARES Act was signed a week ago today. So there may be some in the pre-CARES Act phase that are not paid at the full allowable. Okay, just a couple other points and we'll open it up. I know I'm trying to make up for time. Liability protections for clinicians who volunteer during the public health crisis. We're still pushing for liability protections for all of you during the public health crisis, whether you're volunteering or not. Don't know if that's going to happen, but that's where we are. And of course, for manufacturers. Good news on the sequester cuts. They've been around for a long, long time. The -2% on Medicare, that's going to be temporarily suspended from May 1 to the end of the year. So that's a good thing. The GPCI floor of 1.0, this is part of the Medicare extenders package, will be extended to December 1st. It's particularly helpful in rural areas where the natural GPCI would float below 1.0. North Carolina, it's about 0.91 to 0.90. So you pick up, a 0.1% on Medicare. It's not bad. Not bad. We'll take every little bit we can get. Hospitals are going to receive a plus 20% add-on for their inpatient services related to COVID-19 testing and treatment. So the hospitals will definitely be taken care of there, and obviously in that public health fund that we talked about earlier. Okay. I think as you heard from Brian, the SBA PPO, I said PPO loan. I'm sorry, this was done so quickly. It's PPP loan program. Lisa's laughing. You should be laughing. I have a face for radio. That's why my Zoom is not on. The PPP program is a no-brainer for most groups. The $100 billion public health fund has promise, but we don't know the process yet. We're advocating for a process. We're at the table, and more will come on that. The accelerated advance payments programs, that is the fastest way to get cash in. And be sure to capture your data on your testing and treatments to optimize your government and commercial health plan reimbursements. And for those of us who are slightly cynical about the prospect that Anthem and United Healthcare are going to pay the full allowable amount for COVID testing and treatment, we want the data to come back and say, you remember when you said on your website you were going to pay for testing and treatment? Well, here we are on the back end claiming for that. Okay, Lisa, are you able to unmute folks?
Yes. And I've been trying to keep track of the questions that people put in the chat window. So I'll just start with those
Sure.
before I unmute everyone. Just to do a couple quick ones maybe about the payers avoiding patient, the patient part, the avoiding coinsurance, sorry. So a couple questions on that. People asked, can we get that link to the macro that Zotec suggests? And
Yes.
so the macro is sufficient then. You don't have to have one of those Z codes or an ICD-10 code that reflects a COVID visit. It can just be reflected in the documentation somehow or in some other way that kind of cohorts those visits or charts that you could then submit to make sure with your payer.
Yeah, great question. Great. I would do both. I would want the source documentation. My colleague Pam Neely is nodding her head. Thank you, Pam. It's good to see her do it because she's an expert in this much more than I. But it's on the coding side. It's best to have the documentation in the macro and the I-10 codes. You want both. You want to be able to produce that source documentation and say, patient Smith presented with upper respiratory and fever. A full workup was done, testing and treatment, and that should be at no cost sharing. So here's the link on this page, zotecpack.com, COVID-19. That's where all the documents are. If you look down on the computer screen makeup there, down on the lower left, it says COVID-19 CPT code and macro. That's where our macro is. Just click on that and you'll see the macro.
Okay. And then regarding the advance payment.
Yes.
I think that was actually covered, that the interest is just on any balance that remains after that 210 days of recoupment occurs. Correct. And the interest amount, the interest rate will probably vary based on your MAC, whoever is dealing with that loan, and it would be most advantageous to just try to get an extension so the interest never applies. Right. Okay.
Correct.
And then I think most of the questions were about the payroll protection. Yep. I think a lot of the questions revolve around who's actually considered part of that kind of employee. Does it really have to be someone that's on a 1099? A lot of us have owners, partners who don't get a 1099. They're paid in a different way. Could it be, if your group is made up of all independent contractors, can the group apply for these loans as a whole and include all of the independent contractors as employees? Can we take the first 100,000 of earnings for any of owner or partner and kind of submit that as part of the payroll protection? A lot of questions regarding that.
Brian, you want to take that one?
Brian.
I thought you were going to take it, Ed. So there's that question has several answers, and I apologize for that, but it does really depend upon the structure of your group. And so in instances where you have several different groups that may be made up of 15 different S-corps into an LLC, and that LLC may have employees within it. And so the way we viewed it and our understanding is that separate LLC would have to do its own PPP loan application to cover those W-2 employees. And then if each of the owners are S-corps or some other entity, they would have to file separately. So you could have, in that scenario, you could have 16 different loan applications to cover the folks within one entity.
Okay. Thank you for that.
Yeah, Lisa, if I could add, many of you are familiar with Heart Health, and here is what Heart Health has said about employees, and they're citing two provisions in the SBA website that say SBA will treat an independent contractor as an employee where there's evidence of an employer relationship. SBA considers the totality of circumstances in determining whether the individuals are employees of a concern. Just know that this question of whether or not someone's an IC or an employee can get a little bit involved. But I think we very much certainly trust the Heart Health folks, but that's something to talk to your advisors about for sure.
Okay.
And you would definitely want to coordinate with those independent contractors, because in some cases, the independent contractor may not be necessarily working solely for one party. So for them, they could file separately and obtain more as a separate individual than they could combining themselves with one group.
Okay. And then there were several questions about, with the payroll protection, what can you use the borrowed money for? And could you go over what part would actually be forgiven? My understanding is that the list of things that you can use the money for is longer than the amounts that will be forgiven. And specifically, there's questions about when we talk about insurance premiums for either of those categories, can you specify if you know if it can be used for health insurance premiums, med-mal premiums, any other type of benefit premium, or is it kind of broadly defined at this point?
Okay, so I'm going to say, first of all, med-mal would not be included.
Okay.
When you're looking at whether or not the health benefits and the retirement benefits are in addition to the 100% cap, or they're included in the 100% cap. What we have seen, and we have several folks that work in our practice management group that are all trying to take the information we're getting from the banks, and obviously we're reading the legislation and all the guidance. What we're seeing from the banks is calculation sheets that include the benefits so salary, benefits, and then the 100% cap. And we see calculations where you're able to say salary, cap at 100, add on your benefits, add on your retirement. The language on that is such that they use the term compensation and they use the term payroll cost. They define that as part of what you can use to apply. And then when you read the language that states what's going to be forgiven, it confuses the two. So it's not clear. But at the end of the day, if you were to overborrow, the answer would be, well, I have a 1% loan that I got to pay back over 2 years. Is that the worst case scenario? Mm-hmm. So that's kind of a way of looking at it that we've all kind of come back to.
Okay. Could you speak to what previous payroll is used to calculate the amount that you're able to borrow? For example, if someone's group has changed greatly in size over the previous calendar year or previous 12 months, is your experience that they would be able to take the last quarter's worth of payroll expenses, or are they really looking at the last full year, or is that kind of depend on the bank that you're working with?
It has depended on the bank, because there was some original language that said it's from February 15th of last year through June of last year. Okay. And because that would be the same period that you're eligible for forgiveness of this year. So you would actually be comparing 2019 data to 2020, but you may have changed drastically. Mm-hmm. Personally, I chose to use the 12 months going back from March 31st, well, from April 1st of 2019 to March 31st of this year to kind of capture changes that have occurred in our group. So I think that's a little up in the air, and it's really based upon what your lender is going to send out to you for providing, one, the payroll amounts, and then two, your head counts. Okay. Because what they're ultimately concerned about is you don't take the money and then reduce your head counts.
Okay, thank you so much. You guys, I'm gonna, just fair warning, I'm gonna go ahead and unmute everyone. Feel free to remute yourself. But I just wanted to open it up a little bit more.
Yeah, if you're not speaking, just put us on mute, please. Thank you.
Feel free to remute yourself. And then I just wanted to open it up for more questions so that we could have a little bit more back and forth. So again, if you're not speaking, go ahead. Yeah, thank you.
I have a question for Ed. Ed, you talked about the uninsured will be temporarily enrolled in Medicaid.
Yes.
to pay for the testing treatment. How does that enrollment occur? Like, who initiates it, or how does Medicaid know to temporarily enroll them?
Yeah, again, guys, if you're not speaking, please put us on mute, please. Thank you. Shanna, all we know from the combination of the CARES Act last Friday and the Families First Act is that the uninsured are supposed to be temporarily enrolled in Medicaid. I don't know if the hospital's going to do that or how it's going to happen. But presumably, if those patients are admitted, the hospital has a huge incentive to make sure that they do get temporarily enrolled so that they can be paid for under Medicaid for those services. So I would say do your eligibility checks through Medicaid like you do.
Mm-hmm.
Maybe have your medical directors reach out to your hospital, your ED managers, and find out what their plan is with respect to the uninsured population. Are they going to try to do that for all patients who were treated and released, or are they just going to focus on the patients that were treated and admitted? I don't know, but clearly the law is funding, and it's actually coming. The funding for this is coming from a natural disaster fund, not from Medicaid funds. It's kind of interesting. So part of the CARES Act funded a disaster fund that's going to pick up the cost of uninsured, and then as I mentioned, the Medicaid programs are going to get, I think it's about 6 to 6.5% of their normal FMAP to do the administration. So everybody's incented here to make sure that the uninsured are enrolled and that their services are paid for.
Okay, perfect. Thank you.
Yeah.
Question from St. Vincent Emergency Physicians in Indianapolis. This is Greg Bowens. And anybody can chime in here, but we have our application for the PPP program ready to go, but is there any indication in your discussions with the HHS about the funding for diminished volume that if we take a PPP loan, we would be excluded from that money?
This is Ed. No, sir. There's no indication that involvement in the PPP loan would exclude you from the public health fund. Again, the public health fund, we expect your biggest loss right now will be your volume and revenue shortfall. So, and that is not part of any part of the PPP loan process or the forgiveness.
Great, thank you.
I see another question on the chat box. If you, let's see, if you apply for a PPP loan and then during the subsequent 8-week period, those on your payroll, if that amount decreases, is the decrease in the amount of the loan actually based on the payroll dollar amount, or based on the percentage of employees that change?
Ed, I'll take it. This is Brian. Yep. What we understand is that there's a couple of pieces. If everyone is over $100,000, right, and they're capped, then a reduction in force is never going to reach itself back down to below the $100,000 amount, which is $8,333 a month. So if everyone's making over that amount, it's not really that big of an issue to have the reduction. If the folks are making under that amount, then that's where you're looking at if you go below a 25% reduction, is that correct, Ed? That is where you're gonna have a reconciliation of that 8 weeks compared to what you applied for, and it'll be based on the dollar amount that you submitted for and the dollar amount that you spent over those 8 weeks.
Thank you. Other questions? You can either throw them in the chat or go ahead and ask. While we're waiting for the questions, I wanted to throw it out there that EMBC, the Emergency Medicine Business Coalition, which we mentioned at the beginning, is working with different consultants. I know some of us work with practice management groups that have the capability to help stay abreast of all of these changes that happen by the day, week, and hour. But for those that don't work with a practice management group that has the capability, or if they just want to kind of offload the mental weight of all these applications and keeping up with the process over the next 6 months, we are working with some external vendors who might offer that service as sort of an add-on to the folks that you already work with practice management or RCM. And we're working with them to see, how many of the members of EMBC might be interested and what kind of price we could negotiate, kind of a flat fee for those ongoing services. I see another big question popped up here. Let's see. Maybe we could delve into telemedicine a little bit here. So let's see. Is it realistic to be able to bill a level 5 given, the constraints on doing an actual complex medical exam?
Yeah, I think, Lisa, it's probably difficult to say that an 8.5 customarily would be achieved via a telehealth E&M visit, given the documentation standards. Remember, even though, and it was a great news that CMS is now going to reimburse your ED E&Ms in telehealth, the documentation standards for the 9928X codes haven't changed. They're still in effect. So your high-level complexity decision-making, your comprehensive histories and exams, those are still required. All of those elements that were in place through the documentation guidelines exist today. Again, if you're not, I'm sorry, if you're not speaking, if you could put us on mute, please. If you're not speaking, please put us on mute. Guys.
I'm going to go ahead and mute everyone, and if you have subsequent questions, why don't you just put them in the chat box? Ed, I'll unmute you in a second. Go ahead, Ed.
Okay, sorry. I don't remember where it was. Anyway, so the documentation standards for the ED E&Ms have not changed as part of CMS's now allowance for the reimbursement for the ED E&Ms via telehealth. And remember too, this is during the public health crisis. Okay, for a long period of time, for years now, CMS has maintained that they did not have authority under the law to allow for reimbursement of the ED E&Ms for telehealth. And they believe that they received that authority during the public health crisis under the aforementioned COVID 3.0 and 2.0 combined. Mm-hmm. So once that public health crisis is gone, I think the big question is whether or not we will end up going back to the situation where the patient will have to have been in a rural area for the telehealth to be reimbursed by Medicare. So we simply don't know. So I would put a caveat around that, and I agree with the questioner's tone of question that it's probably doubtful on a routine basis you're going to see a 99285 service through telehealth.
Folks are mentioning some examples where it really might be critical, kind of critical level of medicine. For example, if you're providing medical direction for EMS, what about even directing CPR for EMS? And then there's a specific question about, is there any role for using the kind of acuity caveat for any of these interactions in terms of level of service coding?
Well, I mean, the acuity caveat is part of the 99285 code, so presumably nothing would change given the difference with the platform here being telehealth. So I think the acuity caveat could apply.
Mm-hmm. And then
but in terms of,
go ahead.
If I could just, EMS direction has always been, it's always been a question. There's been a code that's existed for that for many, many years. I recall off the top of my head, without researching it, there are no RVUs associated with it, and it's not reimbursable largely by anybody. Now, if you're doing a telehealth encounter, that potentially changes everything. Then you're outside of that unreimbursable code into a potential telehealth ED/E&M code.
Mm-hmm. And related to that, there's a really interesting question too about, you know, especially during this time, patients might try to take advantage of these telehealth encounters in order to avoid what they would have typically come to the ED for. So and as much as I'm going to just go out and say, as much as I'm envision that you wouldn't be able to use the 9928 anything for if the patient is physically at home, that's a really interesting point that maybe it would have been or should be able to code that way. I'm assuming that for any EM doc who's doing a telehealth encounter with a patient who's physically at home, that would be potentially like the outpatient codes.
I think, Lisa, based on the CMS clarification, it would be the ED/E&Ms. If the doctor is in the place of service, if he's in the department and he's doing the telehealth encounter, I mean, the analogy would be, let's say now under the new EMTALA waiver, the patient's across the street and the doc, you know, they present with upper respiratory and a fever and it's suspected COVID. And the doctor's sitting in the department and the patient's over in another building, you know, a block or two away. The doctor's going to bill place of service 23 ED/E&Ms. I don't think if you took the patient another 5 blocks down the way and they're in their house, I don't think that's determinative of the ED/E&M.
And regarding the telemedicine coding, we are getting just some comments on the chat that say, you know, the critical care codes are certainly included, just as the ED codes were added, and that although procedures need to be in that face-to-face encounter, so CPR might not be included, to keep in mind that those critical care codes have been added with the place of service 23 as per typical. As
has observation. So if you had a separate area where you were putting patients in observation, or there was a delay in testing, and you otherwise met the OBS requirements, either the same day codes or the treated and discharged on different day codes, again, the full CPT requirements would be there, as would be the Medicare MAC rules around those codes. If you meet the definitions of those codes, our job is to code the most appropriate code to match the services provided. So we would use an observation code if the requirements were met.
And there are a lot of messages now about telemedicine coding and billing. There was just an ASAP call on this, so thank you to, I think it was Aaron, who just clarified that at minute 33 on that CMS call today, they did clarify that you can use the ED codes even if the patient is at home. And then on our chat here, it's saying, well, what if the doctor's at home? And I do believe it's also been clarified that if the physician is at home, but the patient's in the ED, then the place of service is still 23, and they're requesting that 95 modifier, and we use the typical ED codes for that scenario as well.
Well, that's good to know. I didn't know the latter part of that.
Let's see, reading some comments. Thank you guys for so many comments and questions on this chat. I think I've covered all of them. Please copy and paste if I missed your question.
Lisa, you've done exceedingly well as chat hostess.
I think I'm just trying to make up for the pornography portion in the beginning.
We're going to have next time we're together, we're going to have a funny laugh about this.
Thank you to anyone on the call who doesn't know what I'm talking about.
Yes, thank you. Anyway, and as I did at the start, I want to apologize for the tech issues that we had with WebEx. I still don't know exactly what happened there. And again, triple thanks to Lisa. As a true EM doc, she wasn't phased at all. She's like, yeah, I'll set up a Zoom. And it's like 2 minutes before we're supposed to start. So thank you again for that.
You
But
guys,
that's how you roll.
So again, I think okay, a question. If a doctor's at home to avoid exposure, and then do you still bill the place of service 23, or do you use the office codes? From my understanding, and Ed, correct me if I'm wrong, I think the clarification has been you still use place of service 23 with the ED codes, not the office codes, even if the physician is remote. And in fact, they clarified on the CMS call today with the ASAP staff that, in fact, if the doctor is physically in the ED and the patient is in the ED, they would not actually even consider that telehealth. They're just considering that we're using special technology to interact with our patients, and that you would code that without the modifier 95. But if you are remote, including at home, then that is considered telehealth, and we should use that 95 modifier. Yeah, isn't that interesting?
That's good.
Mm-hmm.
Yeah, so if you're doing, like I know, like Dr. Booker in DC uses teletriage. So if he's using teletriage, he wouldn't be able to do telehealth per se, according to what CMS is saying.
And I mean, the CMS staff who was on the call was like, I'm going to give a very corporate answer here. Really, my interpretation was he was basically saying it doesn't matter for the part of reimbursement. You know, we're going to reimburse at the same value for the face-to-face versus telehealth. But technically, from a CMS standpoint, if both the provider and the patient are both physically in the same place, we don't actually consider that telehealth. We just consider that you're using technology to interact with your patient. So just to confirm, if the physician's at home, I'm seeing other confirming comments here too, that everyone, at least on this call, is in agreement. Physician remote, not in the ED, yes, use place of service and 23 with the 95 modifier for our typical ED codes. And Kara, I see your question. I think it would also still, that same line of thinking would apply to a physician if you're at a different facility. If the, you know, any remote place, if the physician is at a low acuity facility, if you're at an urgent care, if you're at a freestanding, and you're doing telehealth in to assist at your main hospital's emergency department, I think that same recommendation would apply. Use the place of service 23 with a 95 modifier. I think they're going off where the patient's presenting to. Mm-hmm.
Good, and I'm actually getting a few text questions just to clarify for the Zotec folks. The tech issue that was involved here was all WebEx. It was not a Zotec platform or server problem. It was a WebEx problem. And so just to put everybody's mind at ease, because I know with all of us working at home and the servers are really taking a much heavier load. No, we've identified it now as it was a WebEx issue. So I'm not doing a commercial for Zoom. I'm not a paid spokesperson, but just happy that we were able to facilitate it. And again, Lisa, we did start the recording a little bit late. Sorry about that with all the flurry of stuff, but we got, I think we got 90+% of what Brian presented.
Yeah. And
we will post that here on this website. You'll see there's a WebEx recording we did yesterday for our clients. It covered, Brian spoke to that. We also had an outside counsel talk about unemployment. So if you have questions about unemployment, there is an extensive discussion there by Ron on unemployment. It's linked there at the bottom. You can just click on and watch the WebEx for that. So just FYI.
And I'm going to just throw my email address up on the chat for anyone who has follow-up questions. If you want to be connected with anyone that was on this call, or if you want to have more questions about EMBC, if you want to ask Ed or Brian about how to get more resources from Zotec or anything really going forward, I'm happy to coordinate and connect people. So unless anyone has any other questions, I think we'll close it down there. And thank you so much again to Ed and Brian. I have one more question. Sorry, I have one more question. When an urgent care provider calls the ED, you provide consultation regarding the discharge from the urgent care. You're doing a peer-to-peer professional, doing a peer-to-peer. Is that, are we now considering that part of the codes that have been opened up for in this time of public health emergency, that kind of more, I'm imagining it from my standpoint, more of like the telephone codes, probably not telehealth. Right.
Yeah. So I think we've gotten clarification. The we can at this point, that telephone only would not qualify for telehealth.
Right.
That you would need a Skype or a FaceTime, some combination of video and audio. I didn't mention this, but the HIPAA rules around that have been relaxed. That's why we're able to use Skype or Zoom or FaceTime as a method for the telehealth encounter. But phone only would not constitute telehealth.
Mm-hmm. And what about for those, aren't there new codes that have been opened up to emergency providers as well in this time of PHE that are phone only? My impression was that those were for provider to patient, like the quick check-in codes.
Yeah. There are some, and I don't have those handy. Like, you have somebody like my mother's age, she has a flip phone. She doesn't have a smartphone. So how do you do a FaceTime or a Skype with them? You can't. So there are a set of codes for telephone only consultations, but they would not be, of course, the telehealth ED/ENMs that we've been talking about. And
I think it was Ed that posted that question. I think that the telephone only codes that have been opened up are for provider to patient, not provider to provider for that consultative service.
Correct.
But I'll personally send it out to this group if it gets clarified otherwise, if I'm off.
Very good.
And Brian and Ed, I don't see any more questions, but thanks upon thanks upon thanks on the chat. So if you guys can't see that, I just want you to know that everyone's so thankful and really, really appreciate your time in this week when you guys are especially busy.
Well, and thank you all again for being there on the wall for all of us. And, you're in our thoughts and prayers.
Oh, Dave Friedenson says there are phone consults for viewing an image or EHR and giving the info back to the urgent care doc. I don't know if Ed, you're still on 99446 to 99552. I'll have to look those up.
Well,
Thanks,
maybe
Dave.
we can you post that as a follow up to the group?
99.
Yes, thank you, David. That's very helpful.
Yeah, let me look those up. Thanks. Leave it to Dave.
Takes a big community.
Okay, you guys, I think I'm going to sign off.
Okay.
Thanks, Dave.
Thank you,
Thanks,
guys.
All right,
Thank you.
Have a good weekend.
You too.
Nice.
Bye-bye.
Bye.